Hopefully, you enjoyed Jalanina last night, and I'm very thankful that still you managed to come on time for this lecture. And as discussed in the previous lectures, nowadays implantology has become the butter of maxillofacial surgery. There are various systems, or such as the conventional implants, the basal implants, the zygomatic implants. All types of implants are being used for different scenarios. So, what is that we are going to stress on zygomatic implants? See, the basal implants or the conventional implants are not being restricted for maxillofacial surgeons only. All other implants can be done by a graduate, as well as different fraternity people are doing wonderful stuff on that. But this is the area, that is the zygomatic implants. I feel this is the area of expertise for maxillofacial surgeons only. We have the capability of doing those implants in the most wonderful manner. At the same time, we have the ability to operate in such scenarios where other people find it difficult to operate. So I would like to suggest that if you are doing into implantology, you should go ahead and learn all the types of implants, whether it is conventional implants, basal implants, or zygomatic implants. All implants have got their indications where we can get optimum results on those. In particular cases, as if a patient is having loss of maxilla, or the patient is having good amount of bone, then we are going for a conventional implant. If the patient wants immediate restoration, we are going for basal implant. But there are scenarios where we have to stick to zygomatic implant. So what is the need to know, or the areas of concern where we can go ahead with zygomatic implant? So the need is, in case there are scenarios where there is very less amount of bone available in the maxilla, or almost no bone available in maxilla, as in cases of mucor cases that has come up recently, as well as oncological cases where we have to do or remove the maxillary part as a whole. So that scenarios make sure that a conventional implant or a basal implant is not an option at all, because there is no maxilla over there. But in such scenarios, we can go ahead with the placement of zygomatic implants. End of the day, the rehabilitation can be achieved with zygomatic implants in the most successful manner. At the same time, giving the results or the tooth in the mouth in a very small amount of time, and immediate restoration is quite possible over there. So one need is that if there are congenital anomalies, or you don't have maxillary bone over there, or it has been lost due to mucor, or because of oncological treatments, or surgical oncology has been done in that area, and that has led to the removal of the maxilla as a whole. So that scenario asks for zygomatic implant. Second scenario is that if the patient comes to you after a long period of edentulous state, and there is huge amount of pneumatization of the sinus, and the patient is not ready for the sinus graft in that area. That is again a condition where we can go ahead with the zygomatic implants. The third scenario is that there is severe atrophy of the maxillary alveolar bone. We are planning to go ahead with the placement of the implants, whether it is a conventional or a basal implant, but there is no bone on the alveolar crest area. So how to deal with that? There comes the picture, the zygomatic implants. In case you have done the direct sinus lift for a severe pneumatization of the sinus in a maxillary maxilla for a patient, and the patient comes to you and you see that there is total bone rejection or graft rejection has taken place in that area, and you are in a situation what to do next, then you can go ahead with the replacement with the help of zygomatic implants. The last scenario is that the patient is ready for the grafting procedures, but somehow we cannot go ahead with the grafting procedures because there is vascularity issues or any comorbidities are present in that patient, so that we are not in the position to do grafting in that scenario. In such scenario, the option of choice is zygomatic implants. There is a very important classification, or we say classification of the maxilla that was given by Procedural, and it tells about the zones of maxilla, that is zone A, 1, 2 and 3. This is a very important slide. If you go through this, zone 1 is the premaxilla area, zone 2 is the premolar area, and the zone 3 is the molar area. Supposedly, if you are having bone in zone 1, and zone 2, what will we go ahead with? If there is bone available in zone 1 and zone 2, yes, there is no need for zygomatic implant as such. In that scenario, you can rehabilitate the patient good enough with orient 4 concept. So it is not so that if I am speaking about zygomatic implants, I am going to just push for zygomatic implants. I am telling you in which scenario you are supposed to stick with zygomatic implants. Otherwise, other scenarios you can manage with orient 4 or conventional implant. So there is bone available in zone 1 and zone 2. You can go ahead with the placement of orient 4 and rehabilitate the patient. But there is a scenario, there is bone in zone 1, but there is no bone in zone 2. So what you can do is, you can go ahead with the conventional implant placement in zone 1 and single implant on each side for zone 2. Now happens to be a scenario, there is no bone in zone 1, 2 and 3. Then the area of choice or the implant of choice is quad zygoma. All the prosthesis is being supported on 4 zygomas. Lately there are 6 zygomas are also being used, but that is more technique sensitive, and I am here to make sure that people who have no orientation about zygomatic implant, how to start with zygomatic implants and what are the key points to take care when you are starting with your practice in zygomatic implants. Now, radiological evaluation in that condition is almost the same as a conventional implant, except we give more prominence to the zygomatic bone. So, the dimensions and the quality of the zygomatic bone is of importance because that is the anchorage part, or that is the area where we are going to place the implants. The second scenario is that we have to look for the maxillary lateral wall curvature, because that will give us a brief idea which technique of placement of zygomatic implant we are going to use, whether it is intrasinus, extrasinus or extramaxillary. Then residual alveolar process, we very well know that it is going to hamper. Maxillary sinus condition, what is the sinus condition? Is there any infection or there, or the condition is that the osmometer unit is not cumulative? So we have to make sure that all these criteria have been checked before the placement of the implant. Then the important classification that came was Zaga's classification, and it is very important. It is the classification based on zygomatic anatomy guided approach. So this classification gives another brief idea or an idea of what technique you are going to use for zygomatic implant placement in a particular condition. I'll show you with the diagram. See, this is the condition where this is Zaga 1. The maxilla is totally flat in that area. So if we are going to rehabilitate this patient, we have to go with the intrasinus approach, that is through the sinus. This condition, you can see it is lateral sinus approach. Slight amount of curvature is present. As the curvature increases, we are going from intrasinus toward the extramaxillary approach. Okay, so as the curvature, you can see we are getting increased and we are moving towards the lateral side. So this is the extramaxillary approach, and this is the intrasinus approach, and this is lateral sinus approach. You can see this is lateral sinus approach. Now, while zygomatic implants are concerned, we are supposed to distinguish the 3 areas where the zygomatic implant lands up over there, where it gets its anchorage, where it is present in relation to the maxillary sinus, and as well as in the alveolar crest area. So the areas of concern is the zygomatic implant critical zone, that happens to be the area where the implant and the attachment of the processes happens into the oral cavity, and this is known as the zygomatic implant critical zone. And antrostomy zone, this is the zone where the implant is being positioned and it is in relation to the sinus. And this is the anchorage zone, that is the most important zone, and that happens to be into the zygomatic bone, because we are going to achieve the anchorage from this zygoma only. So we can see this is the anchorage zone, this is the antrostomy zone, and zygomatic implant critical zone. I think this is clear. Now the surgical techniques. There are 3 basic surgical techniques that are involved for the placement of zygomatic implant. That is the intrasinus approach, the extrasinus approach, and extramaxillary approach. These approaches all, as I discussed earlier, depend upon the curvature of the maxilla. As the curvature increases, we keep on moving towards the outer aspect of the maxilla. Okay. See, When it is flat over there, we are going through these areas, and as the curvature keeps on increasing, we are going towards lateral side, and thereby end of the day, this is the extramaxillary approach. Now we have decided what technique we are going to use, whether it is intrasinus approach, extrasinus approach, or extramaxillary approach. Now I want to just brief out with the basic armamentarium that is required for the placement of zygomatic implants. Here happens to be the drills that are coarse and fine drills that are used for the preparation of the osteotomy site. Then this is the preparation of the osteotomy position of the implant that is going to be placed in the position required, and this is depth gauge. These are basic armamentarium that is required for the placement of zygomatic implants. This is the depth gauge, this is the fine grid, coarse grid, diamond burr. These grid, what is the importance of this coarse grid? For the initial preparation of the site, we are going to use the coarse grid, and we will keep on moving towards the finer grid as we reach closer to this sinus membrane, so that the rupture of the sinus doesn't happen over there. This is the driver, and these are the basic drills. Now, the basic dilemma that happens to the maxillofacial surgeons is that we have seen various lectures, we have seen various videos, but what are the key points that you are going to use for the placement of zygomatic implant? So there are two rules, that is rule of 5 and rule of 3. So rule of 5, if you are using a single zygoma, then you can use the rule of 5. That is, 5 is the placement. First 5 is the placement, desired placement of the implant in the emergence profile. That is the area 5th or the second premolar area. This is the area where your implant should come into the oral cavity. It should be 5 mm from the zygomatic crest and 5 mm from the intraorbital rim. So in case you are going for a single implant, you have to follow the rule of 5. But if in case you are going ahead with the placement of 2 implants, that is quad zygoma case, you have to add one more rule, that is rule of 3. The implant should come in the canine area. First implant should come in the canine area. It should be 3 mm away from the intraorbital nerve, as well as 3 mm away from the intraorbital rim. So if you are following this rule of 5 and rule of 3, you have particular landmarks so that you can go ahead and start with the placement of implant. So I have done the marking in that area. Another important thing is that happens over there is when we are making the markings, and it is totally edentulous, maxilla is totally edentulous, and in case mandibular tooth is also edentulous, you don't have the orientation where the 5 is going to come. For that, you can utilize the basic concept of intraorbital nerve block. You just palpate in that area. In the straight line goes the mental foramina. If you draw a straight line, you will definitely get an idea where 5 is going to lie. In case of canine, you can use the nasal floor in that area. From the nostrils area, just give me 5 minutes. Nostrils area, you can mark a line as I have shown over there. That happens to be the canine area. By using these soft tissues also, you can get an orientation where your implant is supposed to come out into the oral cavity. This is the basic dilemma that we face while placing the implants on the initial stages. Though in the later stages, we are quite confident how to go ahead with that. So these are the markings done in that area. For the canine area, this is for the premolar area. Make sure you always mark the intraorbital rim and palpate it yourself so that you can get an orientation. Now you are going to go ahead with the crestal incision, raise the mucoperiosteal flap in that area. See, you have done the marking. I have planned a single implant with conventional implants in the interior, in the premaxillary area. So I have taken a 5 mm distance from the zygomatic crest area. That gives you a landmark over there, from where you have to get the direction in the premolar area. Draw a line in that initial stages. If you are not confident enough, make a point or marking in that area and start with the drilling part. These coarse drills are now being used. As earlier we used to do sinus window on the lateral side and just move the sinus towards the medial side. But these drills are very easy to use. Use the coarse drills in the initial stages and keep on going with the finer grids as we reach the proximity of the sinus. See, you can see the sinus membrane is visible in that area. You just lift the sinus in that area and keep on doing with the osteotomy. You check for the proper direction in that area and go ahead with the osteotomy as desired and start with the implant placement. Once the implants have been placed in that area, you check for the angulations, put the gingival formers over there and just close it. As you can see over here, there is lots of loss of maxilla in that area. So that suffices the need for zygomatic implant. Then the prosthetic part and impressions are done, and that happens to be the post-operative OPG of the patient. And this is a small video that I'll show because sometimes you don't get oriented what I am saying right now. You can see the infraorbital rim margin, crestal incisions being placed in that area, mucocrestal flaps have been raised. This is the marking for the 5 mm from the crestal area. This is the drilling, that initial drilling we are doing in that area with the coarse drill. The sinus membrane you can see over there, we just lift it over there and move it towards the nasal side and start with the drilling part for the desired depth. Make sure, you can see the finger over there, make sure you keep on palpating in that area so that you are very much sure that you are not entering the orbit. So in that situation, that will give you a tactile sensation as well as the idea for the angulation of the implant or drilling to be done. Yeah, you keep on palpating in that area and make sure that it always lies in the alveolar crest area. So I am putting a pressure from the lateral aspect so that when placement of the implant, it is in the desired location also. As I have discussed earlier, that I am not going to go with the coiled zygoma because I had some amount of bone in the maxilla, premaxilla area. Once I have done with the placement of the implants, see, I am palpating over there. Then this is the bicortical implants in the maxillary area. You can see that I have prepared the bed of the maxilla by trimming off at the alveolar crest area so that I can get the desired width available for the conventional implants. This is the bicortical implant engaging the nasal floor. And this is the checking of the orientation for the prosthetic part, healing abutments in place. And this is the prosthetic parts being done, impression. This is the wax trial. And this is the final processes that we have achieved for this case. Now the key surgical points you have to take care is that implants must be well distributed in the maxillary arch when we are using a combination of zygomatic implants with the conventional or bicortical implants. Should be positioned on the maxillary crest with a stable anchorage because there should not be any motion in that area. Quad zygoma, for using quad zygoma, proper arch stabilization should be considered. Although incision torques greater than 35 Nm torque for each implant is ideal, it is not mandatory. Though we can achieve more amount of torque in that area, but if you are getting less amount of torque also, it's fine. Slight amount of movement of the zygomatic implants is accepted because once we load or we connect it with the prosthesis, the mobility goes up. But rotational movements are not accepted. Later movements can be adjusted. Another good point is that we have to take care of the keratinized tissue involved. See, in case you are going for an extra-maxillary approach, you have to make sure that you give the incision, not a crestal one, more towards the palatal side. If you are taking an incision in the more palatal side, you have got a good amount of keratinized mucosa over there. Because the most common complication that happens with the extra-maxillary approach is that the implant gets exposed because there is no amount of keratinized mucosa over there. So you have to make sure while doing that, you have to give an incision more towards the palatal aspect if you are going towards the extra-maxillary approach. Now, to simplify the things, navigations are taken into consideration for the placement of zygomatic implants, but they are a costly affair. But as I have to tell about the basics, I have included this in also in the lecture. This is the various planning softwares available. Then there is surgical procedures, just the static computer assisted approach and dynamic navigation. In the static, we very well know that the sprints have been prepared well in advance. We just put it over there and place the implants. We cannot change the direction of the implants. That is a boon, as well as the dilemma also. Sometimes we want to change the direction, but that is not possible with the static one. So to counter this, we came up with the dynamic navigation, where we can see where we are moving forward and we can make the required adjustments as per requirement. So that happens to be the photographs. I'm not going into the details for navigation because it has been already discussed yesterday, and hopefully I have made you aware to start with the basics. If you want to start with the zygomatic implants, I have not gotten into the details of that, but I have made sure that if you have this orientation, you can start with basic zygomatic cases and start your practice in that, because as has been discussed yesterday also, now implants are the butter of maxillofacial surgery. So all the best from my side, and this is for you. Any questions?
Of anesthesia and zygomatic implants. Many people say that local anesthesia is fine, and many say like general anesthesia is fine. So, what would you advise the beginner to start off with the cases, and what all precautions to be taken in case of like what all is to be done if I am beginning the zygomas?
See.
So, just some words of wisdom.
Yeah, I'll take it. See, if you are starting with zygomatic implants, I will always suggest you to go under general anesthesia. See, there is a condition when we are operating or for the first time, we feel a bit of nervousness, as well as the patient compliance is not that good in case of local anesthesia. You are not sure about various anatomic landmarks, you want to check it twice, thrice. That happens to be the patient also sees in your eyes what you are doing. Okay, at that point of time, I will suggest for initial cases, don't go for difficult cases. Go for with cases that are easy to operate. Do it under general anesthesia. Local anesthesia, we can go ahead. If you have done many cases, you can very well do them under local anesthesia. But I will suggest you to go with general anesthesia and check the landmarks all over again. The positives under GA is that you can check all the landmarks, you can expose all the areas without any difficulty from the patient side. Under local anesthesia, you should need to be very precise. When you are trained enough, you are precise enough to operate, you can very well operate these cases under local anesthesia also, and people are doing that. But for extreme cases, I will suggest for beginners, start with single zygoma with conventional implant, the case I have showed. Don't go for high-fi cases in the beginning itself. Once you are confident enough, you have orientation about the landmarks, you can go ahead. See, with local, the best part is that if you are involving the orbit or something, you will know at the very point of time. That will not happen with case of general anesthesia. So I have stressed on the landmarks that you have to take care. In case of single zygoma, though the distance is 5 mm from the lateral side of the orbit, but generally when we are operating, it is almost 10 to 12 mm. So you have good amount of space available from the orbital area. That is the major concern. At the same time, you can palpate all the landmarks. Your osteotomy drills can be palpated as I showed in the video over there. You can just put a finger over there and get the orientation right. Once you go through all these steps with confidence under general anesthesia, do 5-10 cases. You can do them under local anesthesia.
Sir, one more question. How to verify this? Whether we are placing under general anesthesia, how to verify that the position of the apex of the implant is whether it is in a desired position or not.
I have told you I have showed you in the video also. If you see, I have put a finger over here.
Sir, that is perfectly fine.
Yeah.
What we do in this inferior nerve block, we can hold the mantle from anterior and the posterior aspect, and we direct the needle in between. So it is like what I have perceived from that is we can have one finger here, one finger at the immediate level, and we have to go in between that, and we have to perform the lateral.
I'll tell you. I have told you about the rule of 5.
Yes.
You are going for a single implant or quad zygoma?
Just the single.
Single implant. See, you take 5 mm marking from the zygomatic crest area, position your placement of the implant in the second premolar area. If you mark your infraorbital rim in that area, if you have marked these structures and you draw it, I have shown you that I have drawn a line over there for the orientation. I'll show you. I'll just clear your doubts, because that is here we are for. See, the marking was done. I have drawn a line in that area. Don't go just by assumptions. Draw a line for initial cases and you can get the orientation perfectly right.
That's the part out was how to verify it radiographically. Like we do in our just normal implant cases, we take a RBG and just the conventional or the basal.
For that you have to go with navigation surgery if you want to have a light feedback over there. Otherwise, follow the advice.
I was just asking that you have told about this GA in the initial cases. Can we have the support of the CM or some orthopedic setup? If it is there, then can we do this? Can we have the
CM will give you a two-dimensional image. It won't suffice the need.
Yeah. Okay. Thank you.